Welcome to the Osteoarthritis Action Alliance Lunch and Learn from May 2015. My name is Kirsten Ambrose, and I appreciate all of you taking the time to join our webinar today. I'm pleased to introduce our presenter, Susan Murphy. Dr. Murphy is Associate Professor in Physical Medicine and Rehabilitation at the University of Michigan and Research Health Science Specialist, Geriatric Research, Education, and Clinical Center at the Ann Arbor VA Healthcare System. Dr. Murphy's primary research interests are in understanding the relationship between pain, fatigue, and physical activity in people with chronic pain, and developing and testing rehabilitation interventions for people with osteoarthritis and other chronic pain conditions. Dr. Murphy uses ecological momentary assessment to measure symptoms and physical activity real-time in the home environment. Her lab focuses on testing a tailored behavioral approach to teaching activity pacing for pain and fatigue management to people with osteoarthritis and back pain. Today's webinar is titled Self-Management of Osteoarthritis, an Emerging Role for Health Professionals. Welcome, Dr. Murphy.
Thanks, Kirsten. Thanks, everyone, for being here. I am an occupational therapist by training, and largely my work's been in osteoarthritis. Today we're going to talk mainly about self-management and not about some of the other areas that were kind of introduced of things I do. And hopefully you'll come away with having kind of a broad perspective about what's going on in OA research as it can apply to rehab health professionals and other health professionals. Not sure why I'm just sort of paused. I was trying to advance. Okay, there we go. The objectives for today, I'm going to provide a background regarding current OA management guidelines and some emerging areas in osteoarthritis research. We'll talk about some directions that have implications for health professionals in particular. And then I'm going to talk about one study that we did that will provide sort of an example of ways in which health professionals can contribute to management of osteoarthritis. And in that study, we just had people with knee osteoarthritis. And primarily what I do is work with people with hip and knee OA. And a lot of these strategies can be applied to people with hip OA too, but it's just that the study really focused on knee OA. So that's where I'll be talking. So why do we care about osteoarthritis? I guess if you've been on these other webinars and are interested, you probably know some of the things that are on this slide. But osteoarthritis is one of the most prevalent chronic conditions among adults in the United States and worldwide. In the United States, it affects about 27 million adults. And by 2030, it's estimated about a quarter of U.S. adults will have doctor-diagnosed arthritis, predominantly which is osteoarthritis. A study came out pretty recently that was talking about the lifetime risk of developing symptomatic OA, and it's pretty high, in which 40% of people are expected to get knee osteoarthritis at some point in their lifetime, and 25% are expected to get hip OA. So pretty much if you live long enough, either you or someone you know will have it. The leading cause of pain and disability. And rehab people, which I assume a lot of you are, will have seen people with osteoarthritis and know that it commonly affects the ability to engage in activities of daily living and walking and stair climbing. Hip and knee osteoarthritis are about the most common forms of osteoarthritis and the most disabling. Knee osteoarthritis in particular puts people at risk for mobility disability more than any other chronic condition. So that's pretty staggering. So how is knee osteoarthritis treated? Well, people can have osteoarthritis and have no pain and never seek treatment. But usually people will have pain. That's when they start to seek treatment. So they'll come to their doctor and say, oh, I have knee pain. They'll get an x-ray. They'll determine that, oh, I'm sorry, that was a leftover thing, if you saw that pop up. They'll determine that you have knee osteoarthritis from an x-ray. And from there, people tend to have one of three things happen. They'll have some drugs prescribed. They may be referred to PT, physical therapy, which doesn't always happen, or they may get joint injections. And this is really the toolbox of the person that, of the primary care person or the rheumatologist. And what happens is there tends to be a treatment gap. And I kind of like that terminology because it's really, sorry, leftover VA stuff here. The treatment gap is where there's a large number of people that just have pain and they're kind of waiting for a more invasive treatment like joint replacement. They might have tried some of these therapies. They may be on some medications. They may be doing joint injections, but it's really not sufficient. And they're just kind of waiting and trying to figure out, well, what's the right time for me to get the joint replacement? And this is a problem. We're not really managing people well. And it may be due to a lack of access of conservative strategies such as rehab or other forms of self-management. And we know that people don't really adhere very well to healthy behaviors that could actually improve their trajectory of pain and disease over time. So the one thing we don't lack in osteoarthritis is management recommendations. And there's a ton of them, and from many, many organizations. And what's nice is they all kind of say the same thing. And basically, if you look at this triangle on the left, you'll see what people are supposed to get. So the arrow below says the numbers of people, and that kind of shows that most people, well, all people should be getting education, they should be losing weight, they should be involved in lifestyle interventions. And then as you go up in this triangle, like less and less people should really need this treatment. So the recommendations really have it weighted towards conservative strategies. However, there's really a disconnect in how treatment's provided. So it's sort of this top-down thing where people are kind of waiting to go see the doctor, and then by the time they get there, there's a large number of people that are getting joint replacements, and the increase in joint replacements over the last 20 years is incredibly large. It's about like 680% or something of an increase. So a lot of people are getting joint replacements, and there's not as many people getting kind of the more beneficial core interventions, which involve self-management and lifestyle. So what are the consequences of not intervening earlier with these people? Well, there's personal consequences for the people themselves. And a lot of this is from kind of the perspective that people think there's nothing that can be done until my knees or my hips get bad, so they kind of wait. It also is further complicated by people just trying whatever they see in Reader's Digest and on QVC and untested folk or herbal remedies that have really no evidence base behind them. And by kind of ignoring the things that work or not being exposed to it, they really have the potential for a worse disease or pain trajectory. In addition to the personal costs, there's economic and societal costs, really contributing to the high healthcare costs, the very expensive hospital procedures, and the cost of people not being able to engage in their valued life roles and having work disability. For health professionals, I believe there's consequences too, because it really limits our opportunity to increase the evidence base and really be in the front line of shaping management recommendations. And areas that I kind of see where it would be really nice if people like occupational therapists and physical therapists were a little more involved is extending kind of what outcomes we're looking at, not just pain and physical function, but what about role limitations? What about more holistic outcomes, participation in daily life? So there's a lot of places where I think health professionals could really enhance management recommendations, but we sort of lack the exposure to these people from lack of referral, and then we kind of are limited in our opportunities to really research that. So I'm going to talk about kind of what I'm calling new horizons beyond the biomedical approach. And just a couple areas, and sort of broad areas that I'm seeing in the research. I really think that one place that we can contribute in rehab and allied health is in tailored treatments. There's a lot of research that's coming out that's kind of helping figure out, who is this group of people with osteoarthritis? I mean, they're very heterogeneous. I don't think I said that right. They're a broad group of people, and really, if we can understand the subgroups, there's opportunity for us to provide tailored treatment. And then a better integration of self-management into clinical care, I think, would really advance people's access, as well as kind of the knowledge of what rehab and other health professionals can do for these people. So if you work in a hospital or clinic, you probably are very aware of what the biomedical treatment approach is. And as it applies to joint pain and to osteoarthritis, it's really a more one-dimensional thing. Well, you think that joint pain is due to joint damage, so let's just repair the joint damage. If we relieve the pain, then we can just improve function. So a lot of the focus that you see in the clinics are really, fixing the disease, which is hard in osteoarthritis because there is no cure, and we don't have disease-modifying drugs as we do in other arthritis, like rheumatoid arthritis. But really, the intent is to fix the disease, and you'll fix the problem. But there's a lot of research that says that the disease might not be the problem. Pain severity is not highly associated with the joint pathology, with the severity in the joint. So some people can have very severe OA by x-ray and not feel a lot of pain, and vice versa. And we know that there are other factors that impact physical function and quality of life. And these things are probably familiar to this audience, but like physical activity, having widespread pain, and other symptoms like fatigue and depression. So these factors are information that can help tailor treatments. So some of the emerging areas, kind of where it comes to tailoring, is a better understanding of osteoarthritis pain. And there's been a lot of research lately that's trying to figure out a little bit more about the characteristics of osteoarthritis pain, and that it's not really as simple as we thought. It's not just everyone has knee joint pain and we're going to replace that knee and everyone's going to get better. We're not seeing that. So a couple areas are pain mechanisms, which I'll talk about a little bit, in terms of how people feel pain. So people can have more centralized pain versus joint pain, which I'll describe. And then also looking at pain as it's experienced in day-to-day life. And we've had some development in measures like the ICOPE and other measures that look at things like the persistence of pain, if pain's fluctuating or not, a little bit of work in pain flares that I'll talk about, and activity-related pain. So this is a really brief kind of background of pain mechanism. There's a lot of really good research that's coming out about pain mechanism. And really what we're trying to do with this body of research is to kind of understand, why does one person just feel knee pain and one person feels like an amazing amount of pain with the same input? Because that really kind of depends how we would treat them. So for example, this is sort of a normal pain mechanism where we all have sensory neurons that detect inputs, and they can be low threshold like a feather or high threshold like a hammer. And when it's experienced, say, at the knee, in a normal person that doesn't have any kind of problem with their pain mechanism, you would experience that as low or high, and depending on how what input that is, it will go to the brain, and then the message will come back down in like a split second of oh, I have pain. So that's how most people experience pain. In osteoarthritis and other chronic pain conditions, when you start to have chronic pain, people can tend to, just because of overfiring of neurons, your pain receptor fields kind of widen. So if you have the same inputs as that healthy person in the first slide, you might feel it in a broader area around your knee, like maybe up on your thigh or down on your calf. because there's more firing of neurons, you have bigger pain receptor fields, and it leads to kind of an amplification of pain response beyond the joint site. So you might have two patients that look the same but are experiencing pain in a different way. And the most severe, I guess, case of this is people that have central augmentation or central sensitization. And that's where people have tenderness or referred pain away from the joint, and where they could experience severe pain with just like the input of a feather, or things that don't really would cause pain in like a regular healthy person could really feel amplified to a person that has centralized pain. So in addition of this kind of person having a lot more pain in daily life, there's also other symptoms that are associated with this central augmentation, because it's really kind of a problem with the brain. They have widespread pain, but also have fatigue and sleep disturbance and depression. It's kind of a cluster of symptoms when people have this kind of pain experience. So you can imagine that kind of person is going to be different from that person in that first slide I showed you. So what does this matter for OA treatment? Well, so there's different types of symptom experiences in people that have osteoarthritis. In rehabilitation, specifically, we focus on joint pain a lot of times. So exercise, orthotics, patellar tapping, things that are kind of very specific to lower extremities in treatments, assisted devices to help people with mobility, joint protection education. But that approach doesn't really reach this group of people that have this central sensitization. And there is some research coming out and some review papers, specifically in PT, that are talking about different kinds of therapies like manual therapy and TENS units that are trying to get at this widespread pain problem. But, you know, OT and nursing and other health professionals could really offer a lot in behavioral self-management to people that have this high burden of symptoms in particular. So depending on the type of person that's walking in the door, you know, there could be different treatments that would really benefit them. So another aspect of this tailoring is kind of osteoarthritis pain that's felt in daily life. And there's some more recent research that's coming out about kind of how pain is experienced. So Jillian Hawker has done some nice work in kind of showing that symptoms can be activity related in earlier stages, but maybe more persistent in later stages, trying to look overall across a group of people. And then in a large study at Boston University, they found that people with and without knee OA had fluctuating knee pain. And this fluctuating knee pain was associated with less radiographic OA disease, fewer depressive symptoms, and less widespread pain. So it's really trying to figure out, like, what are the types of people that are coming through? Like, you know, there may be certain subgroups that could be distinct. And another study was showing that pain fluctuation was associated with fluctuation in psychological factors. So knowing more about someone's pain can really help us figure out what treatments are going to work for them. So I'm showing you in this next slide a recent study that we just did on pain flares in knee osteoarthritis. This was actually a really fascinating study because we asked people to define what a pain flare was to them, and then we tracked them for 7 days and asked them to record when a pain flare happened and what were the antecedents and consequences around that pain flare, to try to figure out, you know, did something cause it? What were the effects? You know, how many times did they experience a pain flare? And people describe pain flares, I would say the greatest amount of people talked about pain flares as being a sudden onset of sharp pain and something that was of short duration. So like someone that's walking up the stairs and all of a sudden like doubles over and goes, ow, and then it resolves. So a lot of that, but that wasn't the only thing. So other people would describe like they had pain all the time and then they would have an increase. Some people had pain when they were sleeping. But there was a lot of differences when we looked at the data over the 7-day period in the timing, how long lasting the flare was, and the antecedents and consequences. And this little pie chart here on the right just shows some examples of what was happening around this pain flare. So lots of different activities, and a lot of them were activity related, but not all. Some were, you know, sedentary, like sitting or driving. So what are the implications? Understanding more about these subgroups can help better target treatment. We need to really have some better assessment around, you know, these important kind of subgroups, or, you know, how we can figure out how to match the treatment with what they need. And then kind of a recognition that you will see people, if you're treating people with osteoarthritis, that may have a more centralized pain and a more intense symptom burden that might benefit from a broader approach than just a joint-focused approach. So now I'm going to switch gears and talk about a pilot study that we did, which is called the Engage intervention. And this was a website assisted intervention that's designed to be done in clinical care by an occupational therapist. It probably doesn't need to be done only by an occupational therapist. I think that, you know, nurses or other people could potentially do something similar, but that is my background, and I think that OTs have something really unique to offer in some respects in terms of how to teach health behaviors. So that's what we went with for this intervention. So we adapted a website that people were using for fibromyalgia, which is, if you're not familiar, kind of a widespread pain syndrome. And people come in with a very high symptom burden as compared to most people with osteoarthritis. But regardless of that, really the same kind of treatments that we give for self-management in osteoarthritis is very similar to that of other chronic pain conditions. So it was quite applicable, and we just adapted some specific content about the disease education. The OT's role was to tailor the content for people that was offered on the website and to help people learn and integrate skills in their daily life for symptom management. So it was really combining cognitive behavioral therapy principles and OT expertise. And we had a psychologist on the team that actually trained the OTs in some of the administration of the CBT. So we wanted to evaluate the efficacy of the intervention versus a usual care. So people really weren't getting much, and they weren't getting rehab or anything like that. And we were looking at physical function being the main outcome, but also pain. And we had 47 people participate in a 2-to-1 ratio, so we had like 2 engaged people for every 1 usual care person. They had 8 weekly sessions with an OT, and basically we had them, they came in for a clinic visit, then they would go home and wear an accelerometer. I do a lot of work in accelerometry and wanted to look at their physical activity and their symptoms in baseline week. They were randomized. There were 8 sessions in Engage, and then they had monthly phone contact until the 6-month assessment. Our outcomes were we had self-reported and objective physical function, we had pain, self-report, and we had impression of change and perceptions of treatment. So we wanted to get a lot of qualitative feedback. We had an open-ended survey, and we're asking a lot of questions about how they felt about the mode and delivery of the intervention. Now I'm showing you what a screenshot looks like of the website. And on the left, they would scroll and they could see an introduction. They could look at some modules that were talking about chronic pain, really education focused on treatments and what is osteoarthritis and things like that. Symptom management and lifestyle change. And this is, I believe, the symptom management. If you click on that, that's what you'd see on the right here. And there are different modules. So here, exercise, relaxation, sleep, and pleasant activity were modules. And we had other ones under lifestyle change. Here's an example of the pleasant activity module, and we had kind of experts in different areas kind of presented that way, like in white coats. We had rheumatologists, we had psychologists, different people that did these videos. And so they would watch a little video kind of akin to what a short YouTube video clip would be these days to learn something. And then at the bottom here, they would have downloadable PDFs of supplemental information. They would have worksheets, which was largely to self-monitor, and other activities that they could do. So what the OT would do is they would talk, at each session they would talk about, well, what do you want to work on next time? The person would go home and try it, and then they would come back and kind of go over that topic if needed. They would talk about their monitoring and homework, because oftentimes people weren't great at filling out those things or they didn't understand. And then they would guide the person through goal setting or problem solving to try to integrate the behavior in daily life. And they would assign new homework. So in the study, participants were mostly female, they were mainly white, and they didn't have a lot of physical problems or pain, which is tends to be a lot of people that want to be in our studies, but because we really tap the community for many studies. The flow through the study, we had about 43% of people that were screened came in for the baseline visit. We had 57 people that were randomized, but we had people drop out for various reasons. A couple people dropped out before they even attended one session because they said they had lack of time or it was difficult to get there. But once people began the sessions, we had high attendance of 83%. And just in terms of some results, we did see clinically meaningful changes. I mean, it is a small group of people, but we did see nice effects for physical function mainly, but we also did see some objective change in 6-minute walk, and we saw improvement in pain at a clinically important level. The biggest effects were in the global impression of change, where most people thought that they were very much or much improved after doing the treatment. Interestingly, we were looking at the modules that people thought were most useful, and our modules are here on the bottom axis here. Pacing was one of the most rated as one of the most useful. However, the people that used pacing the most did not tend to improve in pain and physical function. And we're finding that with pacing in our other studies too, and I'm not sure exactly why that is, because I really thought pacing was going to be effective with this population, but we're really not finding effects for pacing, and we're not exactly sure why they rated as most useful. One idea was that maybe it's just new information that they don't normally get. Some suggestions that participants had offered, they thought the materials were a little dense and wanted to provide one module at a time instead of presenting the website that had all the modules on them. A lot of people mentioned that they wanted the sessions spaced out instead of just a week. They wanted more time in between sessions so they could practice a little bit more before they met with a therapist again. We didn't have a follow-up or booster session after the last session, and many people wanted that. And they wanted more specific information about pain and arthritis. We had some small modules kind of organized like in the YouTube type vein, but it was they wanted more content. And then on the right was just a couple quotes that people had, and people really did like the intervention and said a lot of things about how they thought about their pain differently. They were integrating the behaviors and talked a lot about specific things. Relaxation and pleasant activity were very popular, and things like that. So, so it really was kind of a promising area that we could potentially integrate something like this in clinical care. And what was nice about this was having someone with a clinical background who can also provide some feedback about what's going on physically, which is really missing from other self-management programs where it's a lay leader or they're doing things on their own. So I think there's a lot of benefits for this kind of approach. So in summary, OTs and other health professionals currently have a limited role in knee osteoarthritis management, but I think we definitely could have a bigger role. Certainly the development of evidence-based treatments are necessary, and tailoring could really be an area where health professionals can really help shape the research, because we have such a good understanding of kind of what's going on with the disease process and how people are actually functioning in daily life. And I really think clinical care is a great place for self-management education, because people come there at a time where they're having symptoms and they really want to change, and there's a lot of expertise there that can help them. So I feel like that was quick, but I got through it, and I just want to acknowledge our grant support and my collaborators at the University of Michigan, at Wayne State University, and some of my other colleagues that have helped with the study. So thank you.
Thank you very much, Susan. That was very interesting, and certainly self-management strategies and approaches are one of the key areas of interest for us here at the Osteoarthritis Action Alliance as well. So we're always interested in filling that treatment gap you referred to in the beginning of how do we get people to become educated and do all of those self-management strategies before they end up with the ultimate end of the knee replacement. So I appreciate all of your work in this. We do have one question so far, and remember you can text in or press the raise hand button. Our question is, were subjects in the engaged group receiving any other interventions like medical or PT or anything at the time of the study?
They could be on stable medications that didn't change within the last 2 weeks before they came into the study. But if they had any other kinds of interventions like physical therapy or occupational therapy, or any kind of involvement in a lifestyle program or new involvement in a health behavior like physical activity or weight loss or something that they hadn't done for an established period of time, they weren't eligible to be in the study.
Okay, and what were the greatest barriers to participation in physical activity, and how would you address them?
In the ENGAGE study, you know, I think that people, I guess that physical activity was really popular in the ENGAGE study, and I think that it's actually dealt with very well in this kind of format, because people start to have pain when they engage in a program. And we had, you know, a lot of people that were in the study were overweight or obese. So we tend to have people that are experiencing new symptoms, and then they're fearful that they're injuring themselves. So someone like an occupational therapist or physical therapist, if you have that kind of person that can talk to them about how they're engaging in physical activity and exercise, I think that really helps on many levels. You know, it helps them kind of allay some of the fears of engaging in activity. It's really kind of encouraging activity from kind of the medical perspective, like, oh, someone that has a lot of knowledge in this area. And that was rated very highly by our participants, that they thought our occupational therapist was very knowledgeable about all the topics. So I don't think that they had, you know, the same barriers that someone would have, you know, if they were just starting to engage on their own. I think we sort of accounted for some of the barriers, and that was one of the purposes of the program, was really to address the barriers week to week. So so I think it was kind of handled well.
And I think this is just my personal comment. I think this gets to, you know, some of the challenges that we face in a clinical setting where, you know, certainly in a research setting, your participants are somewhat self-selected in terms of them choosing to participate in a study like this. And, you know, it is a little bit more of a controlled environment. I think it's a challenge to translate some of this to a clinical setting where, like you said, you know, you might have somebody walking in the door that's completely new to physical activity, or, you know, that may have significant barriers that need to be addressed.
Yeah, absolutely.
Another question, could you say a little bit more about how the 7-day activity monitoring was used to randomize, or if the information was given to OTs in advance of intervention to help guide goals or activity pacing?
It wasn't in this study. We actually have a whole large trial where we had people wear the accelerometer and input symptoms 5 times a day for a week. And then we fed that information to therapists in a tailored intervention. In this study, we didn't provide that information to the occupational therapist who was treating. We simply were using it as a secondary outcome measure. So we wanted to get an idea of physical activity. We did make it an exclusion for some people if they were very poor at adhering to the watch or the symptom reporting. We made that a criteria for not being in the study because we figured that those people wouldn't really try the intervention well either, go and do any of the homework. It didn't happen very often. But the accelerometer that we had no participant feedback. It's just something that they wear and they have no idea actually how they're doing with physical activity. It wasn't like a Fitbit or anything. It was just kind of a clunky research accelerometer that had no feedback. So it was kind of a passive, it was only used at the beginning and the end of the intervention too. It was sort of a passive outcome measure collection.
Okay, and I had one follow-up question to the very first question that I asked about subjects in the engaged group receiving any other intervention. You described what other interventions were allowed. The follow-up is, how did you control this against the other group?
The other group had the same, all people had to not be going through treatment. So that was just, regardless of what group they were getting randomized in, no one could start engaging in a program or had just started a program of PT or OT or any kind of lifestyle intervention. So really we're trying to get at people that were stable and that weren't starting a bunch of new treatments.
Great. Well, so far those are the questions that have come in. So unless any last ones come in the next minute or so, I just wanted to thank you again, Dr. Murphy. Very interesting talk on self-management, something that I think is definitely, I wouldn't say missing, but definitely needs more interest in clinical care. And I want to thank everyone else who participated in today's Lunch and Learn for taking the time to attend. And just a quick announcement to tune in for our June 17th webinar with Dr. Catherine Martin. She is a lecturer in the epidemiology group in the School of Medicine and Dentistry at the University of Aberdeen. All of our upcoming webinars, as you know, are posted on our events page on our website and will be posted on our YouTube channel within a few days following the live session. So once again, thanks to all of you for attending, and thank you, Dr. Murphy, for the presentation and for your good question answer period.
Yeah, thanks for having me, and thanks everyone for listening.
And that concludes our webinar today. Thanks everyone, and have a great day.